Rick, and thank you very much for the opportunity to speak to you today. I want to build on some of the comments that have just been made by Anders and also some of the remarks made by the Swedish director of your public health organization, particularly the need for mental health to be seen as something that has to be imbued in all public policy. It has to be a cross-society approach. And what I want to do in the next few minutes is share some of the headlines from a commission that I've been chairing for the University of Birmingham, looking at the future of mental health and reframing the question about whether we should be looking at treatment, but increasingly looking to what the prevention agenda needs to be. And this report will be published in July, so this is a sneak preview of some of the key points. I start with this slide, really just to sort of make the point that one of the things that struck us as we gather the evidence over the last 18 months in this commission is that we start with this principle of do no harm. It's a fundamental teaching within healthcare. It's a fundamental teaching perhaps in many other aspects as well. But we already have, when it comes to prevention and early action, enough good evidence of what works from the World Health Organization, from the work of individual nations, public health institutes, that we could be acting now. We could be changing the business as usual now, and if we don't, we are in a way conspiring to do harm by not acting on what we already know. So what do we know? Well, we already have good evidence about the fact that half of lifelong mental health problems have their first signs emerging in adolescence, maybe by the age of 15. And that 3/4 of lifelong mental health problems have their first signs emerging by the age of 25. What if we could change that? And we also know that mental health is the #1 health issue for children and young people. Yet the treatment gap in so many of our countries is not narrowing. The numbers of people with a need but not actually getting access to treatment in a timely fashion is significant. It is huge. And we know from the evidence the drivers are social determinants, are issues around adverse childhood experiences. And this cartoon from the New Zealand cartoonist Sharon Murdoch, I think powerfully expresses that these determinants and experiences can have lifelong impacts on our well-being and on our ability to live satisfying and productive lives. And if I put it another way, our response to mental distress and mental illness, and I chair a mental health organisation that provides services in North London, has been to address the consequences, to react, maybe to spend late and to spend a lot on those consequences, rather than focusing on the causes up there, and simply addressing that stock of people that have lived experience of mental health problems. We need to be addressing the causes, going back upstream. And the argument that the Commission will be making is that the current business as usual is not working. It's not working for anyone in the way that we need it to work in the future. The demand for mental health care is rising. The gap, as I've said already, between those that have need and access to treatment services is a large one. And we also know that the model that we are operating is one that I would describe as the heroic healthcare model. And indeed, this is not quite a model himself anymore, but from Baywatch, he's a little older than that picture would suggest. But it's really that we are almost operating like lifeguards, diving in, pulling people out, but never really having the time to ask the question, why was this person drowning in the first place? And we know that our healthcare systems globally, according to Public Health England, that contribute about 15 to 25% of healthy life expectancy comes from the labours and hard work of healthcare professionals. There is so much more beyond, whether it's the economy, social, environmental, or relational issues that drive how we and our well-being develops. So we need a new business as usual. And yes, we need to carry on improving access to treatment and support. This is not an either-or, it is about both. But we have a significant legacy of the consequences of failing to address social determinants, of failing to address ACEs in an effective way that will be a legacy that we'll have to continue to address. But we also need to tackle the causes, to act earlier, to prevent or lessen their consequences, to increase resilience and reduce the risk factors that make us more vulnerable to mental health problems in the first place. And fundamentally, as Anders was talking about just now, this is a challenge of how we mobilize a complex, interconnected system of systems around a common purpose, around the promotion of well-being, of the promotion of people's lives. Now, in the UK, this is the total sum that the public sector spends. It's about £772 billion every year. And it's very hard at the moment to properly identify just how much of that is truly spent on actions that are early, that are preventative. One estimate is that we spend out of that 772 billion, something in the region of 5.2 billion. It's probably more than that, but nonetheless, it is hard to be clear, hard to hold decision makers to account for the consequences of spending late rather than spending early. So what do we have to do? The Commission's call to action fundamentally is that we need to change the rules of the game. We need to create the conditions for investment in prevention and early action. In other words, the finance rules are not handed down on tablets of stone that are immutable, that cannot be changed. They are artifacts of human beings and the systems they have been set up to support. In other words, we have a finance system that supports the status quo, and the status quo does not support investment in prevention and early action. And it's only in the last 30 years, certainly in the UK, that we've changed those rules so that we separate out how we spend on infrastructure or how we spend on capital from day-to-day spending. Because before we did that, the temptation to raid that spending on the long term to pay for the here and now was almost impossible for politicians to resist. And I speak as a former Minister for Mental Health. I understand those pressures that are on politicians to get elected, to try and deliver their programs, and the pressures are very real. And we also know that we need to have a system that makes it much clearer and makes it more visible, as it is with capital. By failing to spend on capital investment, it is very clear in public accounts the consequences of that. It is not as visible when it comes to failing to invest in prevention and the social infrastructure that bolsters and buffers us all in our societies. So this requires definitions. It requires clear definitions and reclassification of public spending to distinguish between late spending on consequences and early spending on causes. And this work has begun. Internationally and domestically, certainly in the UK, we need to do more of it. It can start at a local level. It doesn't have to be done solely at a national level. But it is a way of holding ourselves to a higher standard and having greater clarity. And it could start by looking at health spending, at spending on education, and on spending in our criminal justice system. Understanding where those spending flows are now can help us, A, hold ourselves to account, but also help us shift the resources to where they are better spent to prevent, rather than just mop up the consequences. But a new approach to public finances around prevention also needs a new organising principle. And the other call for action that the Commission is particularly emphasising is the need for a shift in the balance of power. Because addressing a complex interconnected system of systems requires co-production. And this is more, much more than just consulting and seeking participation from people with lived experience. It is being equal and exercising power and authority in co-designing and co-creating a shared future. And it's also the case that we need to shift to a fundamental approach around assets. We need to see people in terms of the assets, the skills, the gifts, the talents that they have. And that we can start, therefore, with the capabilities, not the deficits that people have. I think something that is very resonant in the disability movement and which we need to see more clearly in mental health too. That reciprocity and mutuality are key to creating the connective tissues that we need to have between these different systems. We may not break the silos down, but we certainly have to connect them much more effectively. And that's where relationships and networking of this sort is so critical to closing that prevention gap. So just some final points. If we're to achieve the systemic change, rather than just forever piloting and having small-scale programs, then if we're going to break that cycle of spending on consequences rather than tackling causes, then we have to change the rules of the game so that prevention can play on the field alongside all the other spending priorities. We need clear definitions. We need to take a prudential, long-term view about returns on investment in prevention initiatives, and we need to adopt an asset lens and a co-production approach. So I am where I started. Do no harm. This quote comes from a report that was commissioned in England by my successor, Norman Lamb, looking at children's mental health. And I think that quote speaks very powerfully to why we have to change the terms of the debate, why we have to go upstream, and why we have to make sure that we stop doing harm and start acting on the evidence that we actually have, and we set the rules to allow us to do that. The Commission will be publishing in July. I hope you will have a look at it. The University of Birmingham website is where to go. Thank you very much for listening to me.